Hi, everyone. We'll give it just another minute and see if anybody else is ready to pop on so they don't miss the start of our meeting here. All right, we're going to go ahead and get started. Welcome, everyone, to From Vision to Vitality, How to Launch a Clinic Like Maddie's Place. I'm Katie Tolley, again, our Director of Advancement and Marketing here at Maddie's Place, and I am so grateful that you are here joining us for the 5th webinar in our series called Healing Beyond the Crib, Clinical Care and Wraparound Support at Maddie's Place. If you've missed any of the previous sessions, you can find those recordings on our website at maddiesplace.org. You just click the resources tab and you will find them there under Want a Maddie's Place in your community. Just a reminder, the goals for this series are pretty simple. We would just like to walk alongside you as we share what we've learned about launching a clinic like this here in our state. And we just hope to help more communities build similar clinics that care for babies with prenatal substance exposure. So we're excited to share this journey with all of you. On that note, I want to give a little update about our cohorts that we have established thanks to this series. Following last month's webinar, we've added another roughly 20 additional individuals to our list of folks that have joined us. And I need to update this slide, I'm realizing, but we currently have about 240 people connected via about 35 cohorts in about 41 states, as well as Australia and Canada, which we're just thrilled. We feel like that's a huge step toward building communities of hope. So don't forget to follow up with us. I saw a flurry of emails come through where we were included on those around the different cohorts, setting up meetings and trying to get together and at least start some conversations if they hadn't already. So just a reminder that if you are connecting with your cohort, please keep us in the loop, keep us updated. Go ahead and fill out those questionnaires that we have. Just let us know what you guys are up to because we would love to be able to support you in any way we can. It really helps us know where you guys are in your journey so we can figure out the best way to help. So before we get started, just a couple of housekeeping notes just to keep our session running smoothly today. Sean, I'm going to hand it over to you.
So what part are we up to right now?
Just your typical disclaimers.
Yeah, well, I think normally I like to tell everyone I'm not a healthcare expert. So we do have some experts that'll be on the panel today. But I do want to point out as we talk about structures and how we're doing this that we're not providing any legal advice. We're not creating an attorney-client relationship through these webinars. Having said all of that, we are happy to exchange information that we have, give you templates, whether it's articles, bylaws, operating agreements, intercompany agreements, different things that we've prepared, policies and procedures. So the information that we have, we're happy to share. But really, to do this, you're probably going to have to retain your own counsel in your own state. Every state has its own unique laws. Healthcare is a very complicated Byzantine area in any event. And so, but we can give some tips. We're happy to talk to your counsel or whatever as you get going. Yeah, I think that was pretty much the disclaimers. Katie, I think you got your microphone off.
Thank you for that. I'm trying to run a couple of different things all on one screen. So this meeting is going to run pretty standard, like our last couple have. If you guys would like to utilize the chat box, for chatting back and forth with one another, making comments, that kind of thing. But if you have a specific question that you'd like our panelists to answer, please utilize the Q&A feature. So we've got about just under an hour and a half together today. I'll be moderating today's panel discussion, and then our communications coordinator, Carly, will be fielding all of your questions in the Q&A. Again, just a reminder, this session is being recorded, so there will be a link up, hopefully by tomorrow, on our website. If you want to go back and watch any of this or any of our other webinars, share them with anyone you think might be interested. All of that will be on our website. So let's jump into it. Today's session I have been so excited for since we started this, probably the most excited out of all of the sessions that we've held. It's fully focused on the heart of our work, our model of care, and you are going to hear directly from the clinical and family support experts who lead our work here every day. So I'd like to introduce you to Dr. Jeffrey Schilt. He is our medical director. He received both his master's and doctoral degrees in nursing from Washington State University College of Nursing, and with an extensive experience in providing pediatric primary care across urban and rural communities, Dr. Schilt has also worked in urgent care and emergency medicine. His commitment to pediatrics is evident in his years of practice, and he's especially known for his expertise in pediatric mental health, having obtained certification as a pediatric primary care mental health specialist. Dr. Schilt's comprehensive approach to healthcare strengthens our shared mission of holistic, patient-centered care. I'm also excited to introduce you to Misty Queen, our Director of Nursing and Clinical Operations. Misty has spent the last 24 years in healthcare leadership, working in Medicaid for at least the last 12, and has worked on creating proposals across the country as a clinical expert. She's a former ARNP and currently a registered nurse, and leads our clinical operations here. Lindsay Rood is one of our full-time registered nurses. With 18 years of nursing experience, Lindsay has built a strong and versatile background caring for diverse and high-needs populations. Her work in corrections, mental health, and chemical dependency treatment has strengthened her ability to provide compassionate, trauma-informed care in challenging environments. And finally, Kim Dunham is our Director of Family Advocacy. Kim graduated from Western Washington University and began her career working in the public school system. Later, she worked for Spokane County Juvenile Courts as a corrections officer and then as a guardian ad litem, advocating for children involved in the dependency system. Her passion for helping children and families has brought her to the Department of Children, Youth, and Families, where she served for 10 years as a social worker and program consultant. Kim has been involved with Maddie's Place since the very first meeting back in 2017. And as our Director of Family Advocacy, her team supports parents by helping them reach their goals so that they're set up for success outside of Maddie's Place. And I'm sorry, last but not least, Sean Cross, our President and CEO. Hopefully all of you have tuned into previous webinars and know all about him. So I just want to thank all of our panelists for being here today. We're really excited to dive into today's conversation. So Sean, the first question is for you. Hoping you can help us sort of frame today's discussion by reminding us a little bit about why our dyadic model of care really has become essential to the work that we're doing, and what we learned sort of early on about infant-only care versus this dyadic model.
Yeah, no, it's been a real journey because we don't, not all do we not have all the answers, we don't have all the questions. So I like to tell folks that I feel like we're building the plane as we fly it. I think we have stumbled upon some things, though, that could be quite significant. When we started this, we were really focused on the infant suffering from NAS, and we knew that really what was happening in the hospitals wasn't the best methodology. There's still a lot of dependence on providing opioid weans to the infants in the NIC unit, and the mom is separated. Our license only allowed us, when we opened this facility 3 years ago, to provide treatment for the infant, and the infant was our only patient. really we kind of snuck the moms in through a 24/7 visitation understanding with our Department of Health, but technically we weren't providing any kind of a treatment, behavioral or otherwise, to the mom or to the dad. Nor were we considering them really to be our patient in any kind of a medical sense and all that goes with that. But what's happened through our state pilot project and through 3 years of operations, we've treated 161 infants, I think now. But of the 95 parents that have stayed with us, the biological parents, either the mom or the dad, and it's been primarily the mom, of the 95 that have roomed in with their infants, the 49 who roomed in the entire time, of that group, 88% are in recovery today in custody of their infant and housed. Of those that stayed here part-time, 46, 26 are in recovery. So that's about 56% are in recovery. But if you look at the total amount if a parent stayed with an infant at Maddie's place, there 73% of our population are in recovery. That's an unheard of statistic. And when you're talking about 3/4 of our moms having been addicted to fentanyl, particularly, and our babies being born exposed to several substances, not just fentanyl, those kinds of stats are really very intriguing to a lot of public policy people. I can tell you that. So I think while some of what we're doing may not be super unique, the combination of treatment and trying to treat the dyad, the mom and the baby, preferably as quickly as possible after birth, is proving to be a very powerful recovery methodology for both. And so I think we'll see as we get into this when Jeff and others talk, we don't have any longitudinal studies yet on our infants, and the infants can't talk and tell us how great they're doing, but the parents can. And so that's really been the source of a lot of what we're seeing. So it's a long answer to a short question, like a lot of mine are. We really, I think, the dyadic model, I think, is unique. Treating both as close to birth as possible, I think, is unique. I think the non-pharmacological methodology is relatively unique. And we also know that this can be done for about a third what the hospitals are charging in their NIC units. And we're moving into kind of an era where Medicaid is going to be cut back and we're going to have to show efficiencies. And so I think we've shown that. So anyway, that's the answer to that question.
Wonderful. Thank you, Sean. Well, Sean always says he's not an expert. I'm not an expert in this field, but we're going to start asking some questions of the real experts that work here with us. Dr. Schild, I would like to ask you the first question. From a medical perspective, what makes this dyadic model essential for babies that are withdrawing from prenatal substance exposure?
When we're treating both mom and baby, we're seeing a decreased length of stay in the hospital, decreased need for medication use, and then just a lot of good positive bonding between mom and baby. And when we're treating both those, we're able to help moms, work with them, working with our moms team to help those moms develop the skills to take care of their baby. And then we're able to even kind of create this really nice community within Maddie's place. And I think with time, we're going to see that just continue to grow, which will be just real amazing.
Wonderful. Kim, I'm going to ask you a very similar question. Can you talk a little bit how dignity and cultural humility, trauma-informed care show up in our day-to-day work with families?
Yeah, so at Maddie's place, we really try and just meet families where they're at. We're very open and direct with our families. Everybody is here because their baby was exposed to drugs in utero. And so there's really, our families feel a lot of shame in that. And when they come in our doors, they are worried about being judged because they've been judged in the hospital. And they just want somebody to treat them with dignity. And so that's really what we strive to do. We strive to be very welcoming, not judgmental, take the stigma out of it, and just get them started on a path to healing. Every one of them is so scared about what is going to happen to their baby. Many of them have lost other children to CPS, and so we really try and look at the big picture. What has brought them to this place? How can we help them in the short amount of time that we have them? How can we not only try and break down barriers that they're experiencing, but also build them up to help them believe that they can get out of this addiction and that they can parent their baby, and that this time things, hopefully will be different. So we're doing a lot of things, but for the most part, we're really trying to make them feel welcome, not judged, and help them overcome the shame that has brought them here by having a baby that is born exposed.
Great. All right, Missy and Lindsay, the next couple of questions are for the two of you. Can you talk about what a typical day looks like for an infant in our care, and how does our nursing team approach comfort, regulation, and safety for our babies?
Yeah, so our typical day with our infants, it really revolves around our infants. So we cluster in infants' care around when we wake them up. We want to get as much done as possible with them at that time so that we're not interrupting their sleep cycle, so that we allow them as much sleep so they can heal during that time as possible. So we keep the lights dim for them. We don't keep the lights lit bright for the staff. We make sure everything we do revolves around that infant and their needs. So the lights are dim, the music is played at what we consider an evidence-based music. So we're not playing hard rock, we're not playing country, but we are playing music that is considered evidence-based for baby infant learning and development in the brain. We have all of their stuff prepared and ready to go so that when they are woken for care, everything is ready. So we don't have them woken up and then go gather their belongings for a diaper change or a bath. We prepare that, have them ready, and then take the baby to that and get them going. And then using consoling techniques that Lindsay can talk about, try to get them back into a comfortable place to sleep again and begin that rest period again.
I think the two infants that we tend to see here are the ones that come from the NICU, and they're sleepy and quiet. They're happy to be fed, put down to sleep, change diaper, fed, repeat. They don't really give us very good cues on when they're hungry. They're used to a set schedule of a NICU. And so I think with those babies, our job is to hold them, to start getting them to wake up a little bit, start responding to cues for them so that we start creating that dyad, that communication between us and them. And then when we're listening to them, start showing feeding cues, and we're feeding them and we're meeting them right where they're at. They're not going into the fight or flight, freaking out sort of neurochemicals that we don't want them to be processing all the time. So things that we'll do is we have, every baby has a dark room, so we can take them in there if they're overstimulated often. So they'll be crying, they suck, swallow, breathe on top of anything going on around them can really impede feedings. And so watching to minimize, where's this baby at? What environment can they feed best in? If diaper changing them throws them into dysregulation, we're swaddling their top half to kind of keep them all feeling secure during that process. Other than that, like also with feeding, often these babies are not good feeders, and so they have reflux. So holding them upright after a feed, making sure that moms know, or that we know, that we're not overfeeding them for comfort as well. And so just really paying attention to each individual baby and starting that communication, and also holding them a lot, having eye contact and building that sort of rapport, because ideally they're either doing that with their mother or they're doing that with us. And they're feeling like the world is safe and I can bond and I can heal. And then ideally we're passing them off onto mom or foster family. So just really, it's very infant-centered, infant-based.
Sorry, trying to find my unmute button here. Wonderful. Thank you so much. Dr. Schilt, this next one is for you. Some of our attendees have asked in previous webinars around medication use, when medication is necessary, how is that handled, and what does coordination with the pharmacy or the hospital or our nursing staff look like?
So sometimes it depends on, firstly, are we treating withdrawal symptoms depending on how early baby comes to us? If they're coming early enough and they may be getting treated, which is fairly uncommon on morphine, but we can administer morphine in the office or in the clinic, and then we do have oxygen on hand in case those methods are necessary. On top of that, we're doing assessments of those babies. My medical team is, and we're determining, hey, what's going on with them? Are they needing extra, are they having a lot of GI issues, which can occur commonly in these babies? And they may require maybe a reflux medication or something to help with motility for them. And ultimately, any of the issues that we're seeing with any other infant medically, we're doing those assessments and treating them. They get rashes. These babies, unfortunately, do tend to have, as I mentioned, more common upset GI tracts. They can be a lot more fussy and irritable, which most of the time we are able to treat a lot of that fussiness and just withdrawal symptoms with lots of consoling and holding and helping them. And back to the coordination between pharmacy and hospital, we also will get those, we'll obtain records and communicate with the hospital so we have their discharge plan to determine what follow-ups are necessary if we're coordinating additional imaging or if we are continuing any medications that they left the hospital on. On top of that, pharmacies, we're ordering medications from the pharmacy and we get those delivered to the office as well, to the clinic.
Great. Thank you. There was another question, again, in a previous webinar around red light therapy and maybe any other alternative therapies that we're maybe utilizing. I'm just curious if you want to share a little bit about some of the practices that we use, evidence-based practices, or our approach to evaluating emergency or alternative therapies.
Yeah, so we're always looking for different ways that we can best help our babies, help our moms. Right now, I know there's some emerging evidence on red light therapy, but it's not real concrete at this point in time. So as that comes about, as well as if there are other therapies we utilize, physical therapy, occupational therapy, feeding therapy, and they're coming into Maddie's place and helping with these babies, and they're working right alongside our team, which is great. We're always looking and working with Misty a lot to determine, is this a good option for our babies to help them?
Thank you. Misty and Lindsay, I'll let you take this next question, whichever would like to answer it. Are there any special infection prevention or safety rules that we have here at Maddie's Place, and what does that look like?
So we, like Jeff just talked about with evidence-based practice, we do follow the evidence-based practice for infection control as well as for safety. So each baby here has their own room, bassinet, crib, and we use standard infection control practices there, but there are shared spaces. So in our shared spaces, we work very hard to ensure that each baby has their own barrier cloth, blankets, that when they are being held, that they are using their own, they have a barrier between them and the baby, so the babies are not laying across the shoulder of a caregiver, and then the next baby they pick up is doing the same. So we want to make sure that we are creating, as clean as a space as possible for each infant. And then each infant has their own drawer in the diaper changing area that has their diapers, their care supplies, their barrier cloth for every diaper change. And then in between each diaper change, that area is sanitized. We do because we're, 24 hours a day and these babies are not sleeping through the night, they are feeding and getting changed every 3 hours in most, for most infants, we are cleaning every shift. So it's not like at night we do a thorough cleaning. We're cleaning every shift. So, and in terms of safety, we are following, for the majority of everything, we're following the American Academy of Pediatrics. So for safe sleep, American Pediatrics safe sleep practices. And it's very difficult sometimes to explain to a parent what that looks like with their baby, because, my baby has reflux, we should elevate them. And there is no evidence that shows that an elevation of less than 30 degrees is going to be helpful for that reflux. So it's really about educating parents and making sure that they understand what sleep looks like, what safe feeding looks like, what co-sleep should not look like in their case. And so really making sure that we're educating not only our staff, because the staff, again, they come from a place of wanting to help, and they really want to do what they can to help these babies. And it doesn't always line up with what the evidence shows. So it's about making sure we're educating not only our staff, but our families, and whether those families are staying with us, they are visiting, or if it's going to be a foster family, we want to make sure that we are giving everybody that same education so that our babies are in the safest environments possible. Anything you would add?
No, I think you got it.
Wonderful. Kim, this next question is for you. Can you walk us through some of the support that parents receive? Everything from behavioral health to peer support to case management. What does that look like, practically day to day?
Yeah, so our parents are able to stay here and room in with their baby if they can provide a clean UA and if they are willing to engage in treatment. So they would need an assessment and then need to follow recommendations of that. So the big thing for us is getting them here. We want to get them here with their baby as soon as we can. Obviously, they need that clean UA to enter our facility in order to stay with the baby. If they're not able to provide that clean UA, then we do offer liberal visitation. So we have a visitation part of our building that is just for our parents that are visiting. And there, they don't have to provide that clean UA, but they're able to be there from 9:30 a.m. to 5:30 p.m. Monday through Friday, and Saturday from 2 to 6. So Maddie's Place is often an alternative to foster care. So our babies are placed here instead of going into a foster home, which then allows a lot more access to their parent. So we really, hit the ground running when they're here. We sign them up with case management services through folks here at Maddie's Place. So they get case management, they get full-time peer support. We've hired several peer support that can really speak to them and have been in their shoes with addiction. I've also hired several peer support that have come through our program. So parents that have actually come through our program maintain their sobriety, and now they work for us. And they have just been great employees and can really reach the parents a lot quicker than if I were to be trying to reach them, because the families trust them and know that if they can do it, that our families are more able to see themselves doing it. So they get case management services, full-time peer support. We do provide transportation to and from all outings if they're staying with us. So they don't have that desire to take off and relapse. We help them navigate the DCYF system and the criminal justice system if they need that. So really, we just kind of make a list of all their barriers, all the things that are keeping them struggling out on the streets or in with their addiction. And we just try and tick away at those barriers. Often our biggest barrier is that they're homeless. The majority of them are homeless or have unstable housing. Most don't have transportation. Most are in sanction with their benefits. So we work on getting them out of sanction with their TANF benefits or food benefits. A lot of them don't have their birth certificate or driver's license. And so we try and really work on those things that we can do that are going to help them to get housing, to get compliant with their court order if they're involved with CPS, and get them on housing lists. Lots of different things. We do so much here, and we try and just go through all of it in the 60 or so days that they're here.
And one thing, Kim, that's a great list of all that we do, but maybe you can talk a little bit about the thrift store and food distribution, and that we're starting to really expand our services after their discharge, and the average length of stay is 60 days. So we really don't want, so many clinics or recovery facilities or whatever. You've got 60 days or 90 days or whatever, and then it's, hey, we hope this works out for you well. And oftentimes it doesn't. So what we're trying to do is to kind of fill that gap after they leave. So maybe you can talk about all the services that we're starting to provide after they leave.
Yeah, we started out just, while they were here, we would host a couple of different events throughout the year, a Mother's Day event, or we would host them going to a hockey game or something. And we would take them to recovery meetings, and we just saw so much success with that. So we've really tried to expand our services after they leave. I've hired a chemical dependency provider as well as a licensed social worker, and we are, like Sean said, setting up like a thrift store. We've had it upstairs in our facility. We get so many donations that we have an abundance. And so any of our families that have come through Maddie's Place are able to come back to us at any point in time and get diapers, formula, clothing, food. So we've connected with the local food bank, and they bring us food every week. So we're helping our families learn to cook that food, learn to just do basic cares, stuff that they have not learned growing up. You would be surprised how many of them come in and are just addicted to gas station food. And we started out with a really beautiful, healthy menu, and we were going to provide all these wonderful home cooked meals for them. And then we realized every meal we made for them, they hated because it was fresh and not what they were used to eating. We also discovered that a lot of them have a lot of dental problems. And so some of the food that we had, they just couldn't eat. So what we've done is just try and build on all the resources. And again, pack as much in as we can. But then also, we don't want to just send them out after they leave. We really want to create and have created just a community for our families, so they know that they can always come back here. They know even if they're not doing well in their recovery, that this is a safe place to land, and that we're going to be excited when they walk through their door. We look forward to celebrating babies' birthdays and graduations from treatment, and when they get their new house. Anything that we have here, we're happy to support them with. So anytime they need anything, we're hopeful that they'll come to us, and we're thankful when they do, because we do have such good resources and the ability to help them.
And I think we've had almost 50 babies that have come back for respite care. And so as long as the infant is a year old or less, we can do that, and we see expanding that program. So we're trying to provide as much support as we can to help folks stay in recovery and stay in custody and housed.
Kim, I'm going to leave you in the spotlight here. Can you talk about what our approach is when a parent may experience a relapse while staying here at Maddie's Place?
Yeah. So, relapse is part of recovery. We've all heard that term. It is a bummer when it happens. We really do try to ensure that the parents are not using, that they've provided that clean UA, that they're not leaving without us taking them somewhere. But sometimes relapses do happen. And again, we really want to be direct in our communication with them and honest. I've found that usually when I have suspicions from a parent, if they're using, somebody may come tell me, or they may be nodding off, falling asleep excessively. where they hadn't been before. Usually, because we really focus on relationship with them, if I go up to them or one of my staff and says, hey, it looks like you're struggling, would you mind taking a UA for us just to make sure you haven't relapsed? They're almost always willing to do it, even to the point of them just saying, you know what, I did. And it goes so much better when we have those outcomes. And so really what I do is if I have a positive UA or they admit to it, I just, unfortunately tell them I can't have them here rooming in anymore, but that I would be happy to help them go, find somewhere safe to go, that the baby is safe here, that we need to notify DCYF or CPS if the CPS is involved. And then I plan to follow up with them. I've had some parents ask, and apologize and ask if they can come back and try it again. And, there have been times where that was appropriate and we've had great outcomes. Other times it hasn't been appropriate and they haven't been able to come back. But the great thing is, as long as they're respectful and safe, they are still allowed to have access to their baby through visitation. And so we really want to engage the parents. We don't want to see them set back. And so, we just try and normalize it. These things happen. It's a bump in the road. Let's move forward. And there's been some of them that I've had to ask leave, and they said that was the best thing that happened, because after that they went and got into treatment and they started taking it seriously and got on the right track. So there's a lot of those faces in this picture. It's really cool. This was our 3-year celebration this fall, and we had a great turnout of families. Ones that we had our first mom and baby, first mom, second baby to come through. They came and celebrated with us, and then some of our current moms also got to meet them and just see that, hey, 3 years later, these parents still are doing good, and look at how good their babies are doing. So we love when we get a chance to celebrate all our families.
Okay, Kim, one more for you. How do we balance safety for infants with compassion for parents that are navigating recovery?
Yeah, I think that the easiest way to do that, which has worked for us, is just being upfront and direct. Hey, we're all here. We all know why you're here. Obviously, you've been using substances. So in our visitation facility, we do ask that they put on a scrub jacket. Originally, when we first opened, we just had the parents that we thought or we knew were still using put on a protective layer. Then it got to be like embarrassing for them, and I didn't want to single them out. And so we decided just to make everybody, grandmas, aunties, parents, everybody, just to put on a scrub jacket when they come to visit their babies, wash their hands, and then they can visit. So then we just kind of normalized, like, okay, we're all just taking safety seriously here. Again, we UA all our parents that are staying with us, and if we have any suspicions, we'll UA them too. Originally, when we first started, we didn't have the capability to UA them, so we were dependent on DCYF or CPS to do that. We finally did get set up with a provider that does the UAs for us, and so we get a detailed printout of what's going on with them, and we can see firsthand what their levels are, what substance they used, and that has been a great tool for us. It's just billed through their medical insurance, and it does take a few days to get back, so we do sometimes use point of care UA cups. They're not as accurate as the ones that go to the lab, but they will usually be able to show us if a parent has relapsed or is still testing positive in order to stay here. And, we all are just we take the safety of our babies and our staff really seriously. So it would be devastating to us if something were to happen to a baby, if a baby was exposed because of a parent's relapse or because they had something on their clothes or their hands. And so we really do take hand washing seriously. We want those barriers between parents. Even when it comes down to just nicotine, if a parent goes out and smokes, we want them to put on a smoking jacket, come back in, wash their hands, maybe wash out their mouth, so they're just not passing all of that on to baby.
And I think as far as that, just to give the audience a sense of the numbers of, and correct me if I'm wrong, and Katie, there may be more updated information, but the last information I saw is of the 95 moms and dads that had physically stayed with us, of the 161 infants. I think we've only had 14 relapses, something like that. And most of those, I think 9 went right back into recovery. So just to give kind of a sense of the numbers. We're also a very secure facility. So in order to get back beyond the visitation center and the lobby where our administrative offices are, you have a fob. And so everyone, that is back there is an employee or has a reason for being back there. And so we've got cameras throughout the facility. So we can really monitor what's going on, not only outside the facility, but inside the facility to make sure infant care is being handled appropriately and that. So it's a very secure, safe environment for the infants. They're under observation also in the visitation center, and our 5 visitation rooms all have glass rather than just walls, so you can see into each one of those rooms.
Great. Okay, Kim, we're going to add Missy to the mix, Missy and Lindsay. Family visitation and reunification are obviously central to the work that we're doing here. How do we help parents build confidence, build their skills and connection with their baby while they're here or visiting?
And I think one of the things from the nursery we're doing is we're really encouraging moms or parents to care for their baby, but we're not forcing that. And when we do see them doing it, we are giving them praise for like, great job. Look at how your baby's looking at you, doing all of that piece. And then, like Kim talked about, we're working on teaching them skills. So whether that is life skills, cooking, we do a cooking every Friday, and we're focused on foods that are readily available at the food bank or that they can buy with WIC. So, foods that they are getting, and how do you cook with those foods? And what are the basics of cooking? Like Kim said, it's really eye-opening when you start to say, hey, we're going to cook. And I kind of lead the Friday cooking. And I came from a teaching background. I used to teach nursing. And I just remember my first day teaching. And I was like, okay, everybody put in your stethoscope. And I'm like, okay, what do you hear? And they're like, I don't hear anything. And I'm like, what do you mean you don't hear anything? And to me, my mom was a nurse, so it was second nature to me to put in a stethoscope when I was 4 years old and play with it. They didn't know how to put stethoscopes in their ears. They didn't realize there was a right and a wrong way to put it in. They didn't realize you could turn the head of the stethoscope. And it's the same thing. They don't, when I said, okay, go melt the butter, they were like, is this melted enough? Well, no, melted is melted. And so they really just don't have a lot of those basic skills because they didn't sit with their parents and cook. They didn't sit, around, the dinner table and have meals together. So when you say, what do you want to cook next week? They're like, what are our choices? Like, I don't know. They just don't really have that idea of how do you create a meal plan? How do you think about what you're going to eat? And so really just basic things to really build confidence. Like, you can do this. You are a good parent. You are a good person. And so we're really working on every day, giving them positive feedback for every little thing that they're doing. Lindsay?
I think the other thing is just the genuineness of the relationship with the ICSs and the nurses to the moms that are staying here, having those open conversations, but then also pointing out when they're doing something great. I think sometimes they don't see it. They don't realize how their baby's looking at them or look at how they smiled or heard their voice and turned. And so pointing out those things, but also like remembering what they have going on in their life and checking in. How are you today? How's things going? Being a soft place to land. And then also with our moms in visitation, they're not here as much, but we try really hard to remember what are their names and call calling them by mom and dad to just reinforce that bond with them. And when they're, if we hear the baby's crying for a little bit longer, coming in and how can we help you? And, I brought you a swaddle and a binky, or just sort of being like a friend and a helping hand in there, I think. So, and knowing that they can build that relationship so they can ask us the questions and feel safe. What's my baby eating? What are they doing? And giving them opportunities to be a part of their daily care as much as they want. So I think that's it.
Yeah, it's really fun to be able to see our staff modeling for our parents, just kind of what healthy parenting and healthy bonding looks like. I would, guess that the majority of our parents didn't have a really great upbringing. And so it is really neat to see when they do start to relax and feel comfortable here, then they can start really doing that natural, loving attachment to their baby. It's really beautiful when the baby really starts to recognize and prefer them because they know that that's their mom. And, we get lots of our parents just coming back saying, I love Maddie's place. I loved my time there. Everybody was so loving to me and caring and took such good care of me and my baby. And I just think the more that they can see a healthy model of what it looks to parent, they're learning just by us doing our jobs. And so it's a beautiful, beautiful thing when they get to discharge home and then come back to us and just are so in love with their baby and that their babies prefer them.
One thing, so well said, Kim, I just want to give a shout out to Misty and Lindsay. Not all nurses with their training and skill level and everything have the heart that they have for the moms, and that it's just these moms in the health care environment, a lot of them in hospitals, not with everybody, obviously, there's lots of wonderful people in hospitals too, but a lot of our parents feel that they were judged, whether it was OB/GYN or whether it was in the hospital or whatever. And so when we were hiring initially to start this clinic, a lot of our nurses came with a NIC unit background from our largest hospital here locally, and they're not used to having moms that are in recovery in their first couple of weeks walking around right next to them and saying the things they may say and doing the things they may do. And so I think having nurses and staff, ICSs, but really I'm thinking of nurses because of their training and kind of how unusual it is to have the mom and the baby dyad together like this, and to be training them both and modeling and having that heart. That's something that as people are trying to set up these clinics around the country, that to find the Misties and the Lindsays, they're out there obviously, but you shouldn't just presume just because you hire a nurse that they're going to have that kind of a heart, because they haven't been trained for that.
Mm-hmm.
And I don't know if Misty or Lindsay, if you guys want to jump on that, but that was intended to be a great compliment.
Thank you. Appreciate that.
And I taught nursing for, many years. And one of the things that when I still go out every once in a while and do talk to colleges, especially about Maddie's place, but non-traditional roles in nursing. And one of the things they do ask is what background do you need? And I try to say, it's not really necessarily the background, because I can teach anybody the skills you need. What I can't teach people is the compassion and how to treat people non-judgmentally. You really do have to have a passion. I worked in Medicaid for many years as well, and setting up programs for homeless, setting up programs for people that are coming out of a state hospital for a suicide attempt. So really understanding those populations is a difficult population to work with. And so I really think that is one of the most important pieces when we hire, is hiring the person with the right disposition and the person that is compassionate, because I can teach anybody to put an NG tube down. I can teach anybody how to pull up medications and draw up medications and give medications. I cannot teach anybody compassion and how to not judge people, because no matter what you say, if you judge people, it will show in your daily interactions with people. You really have to, love and believe in the Dyad. You have to believe that these parents are worthy of having their children with them, or it will eventually, you will crack eventually at some point, and we will all see it. So,
well said.
Yeah, I feel like that's probably been one of our biggest struggles is finding the right nursing folks to come along the parents, because like Sean said, it's not necessarily normal that somebody using drugs would be able to then be alongside a nurse, and their baby. And so what we're doing is different, but it does show eventually. I say they can only, not just nurses, but just people in general can only take it so long. You really do have to have a heart for this population, or it really will cause a divide and cause issues in this type of facility.
Thank you, guys. All right, Misty and Lindsay, I'm putting you guys on the spot here for these next couple of questions. They're sort of multi-part here. So how does coordination work between nurses, social workers, medical providers? We've got some other external partners as well. We've got ESIT providers. So what does daily communication look like between all of those folks?
It has to happen. We communicate every day with everybody. So between our provider, our medical director, our ESIT providers, so our speech therapy, our feeding therapy teams, every day before we're making changes. If we see there's a problem, our providers are calling us to say, we're going to come in today. These are the babies I'm going to see. What are the problems? We're communicating back and forth between myself and Lindsay. Lindsay's our day nurse Monday through Friday. So every day when I come in, I'm touching base. I'm touching base in the evening before I leave. There are days when I get up and start getting ready. I call the night nurse. How did nights go? Is there anything I need to know? Because I do try to get in every once in a while for night shift just to touch base. I come in on the weekends to touch base. But it's important that all of our shifts know who to contact. Because without communication, we've had a couple nurses that weren't good at communication and things start to fall apart. I know actually this morning, did this baby have MRSA? Did they go in with MRSA? No. Yesterday when we left, they did not have MRSA. What changed? And it's just this game of telephone. So making sure that that's really cleared up. But we are always in communication between myself and Lindsay every day. Lindsay, myself, and our medical director, Jeff, we're always communicating. Jeff is communicating with us and really keeping not only verbal, but we have written ways we're communicating between all the different shifts of nurses. We've got communication with our feeding therapy teams. We have communication between our pharmacy when we have refills coming. So everybody knows, did you order the meds? Am I supposed to order the meds, or are they going to just magically show up on Wednesday? Because then what happens is Friday, we're out of meds. Pharmacy's closed on the weekends. And now what are we going to do? We're going to have to order, emergency fills, and that costs extra money. So really making sure that every player in the team understands who's on first, who takes charge, and when is it appropriate to notify. The other night they said, hey, what about this? I said, it's 9:00. You don't need to notify Jeff. This is what you're going to do. And I'll talk to Jeff in the morning about it. But they knew I need to ask Misty, what do we do in this situation? And so making sure we have open communication, same thing. I do the same thing with Kim. Hey, Kim, this is what's going on in the nursery. Are you okay with this? Do we need to do something different? So that we're never creating divides amongst the peer team versus the nurseries. We really want to make sure that everyone's talking, everyone's openly communicating between teams, between providers. And then Lindsay? You've got the next question. Straight ahead, girl.
So within the team themselves, we sort of follow like a hospital model. So the nurse will meet with the shift that's coming off. So they have a nurse and a lead ICS, and then we have our whole team that's coming on. So we do like a morning huddle. It takes about 10 minutes, talk about every baby, things we need to accomplish, weights, measurements, any concerns babies have, any tips on, well, this baby likes to be swaddled like this, and this baby feeds best in this room. And so we're passing those off. And then in every nursery, there is a binder that has a care plan. So it will specifically say what bottle does the baby use, what formula. So it's very clear who are the parents, what's visitation like, anything that we might need to know as far as the baby goes. And then also up on the boards, we have like recipes on how often to feed the baby. There's a time that we're all following. So a lot of communication is up around us, as you would see maybe like in a hospital on the big board. So everybody's all working together. And then the nurses do a huddle after the whole group so that we can talk about medical things and medical concerns. And then I'm in touch with Jeff during the day when I have any concerns. We're also documenting at the end of every shift. So an ICS will sort of give a baby synopsis. They ate, they pooped, they did all these things, happy, not happy. And then the nurses are doing notes whenever we see anything out of the ordinary. So if somebody comes and grabs us and says, wow, this baby has a rash, can you look at it? We will look, assess, write a thorough nursing note, and then involve whoever we need to from there. So it's a lot like a hospital, but a lot more people and pieces, sort of. But communication is the key. We can see how when we don't communicate or when something's communicated off, I'll often find that I'll say something in the morning, and when it comes back to me the next morning, it might be a different story or it might have morphed a little bit. So keeping everybody on the same track when you have a lot of employees can be a challenge, but I think we do pretty well.
We try anyway.
We do try.
Well, I didn't even have to ask the second part of that question, which is what practices help ensure that continuity. So we're going to bring Kim in on this next piece of it. Very similar question related. So Kim, how do you collaborate with the nursing and medical teams to make sure that the infants and parents' goals are both supported?
Well, I sit right across the hallway from Misty, so we could just yell back and forth. But I'm just joking. But we talk daily. We talk hourly sometimes. We're sending messages back and forth. I'm just down the hall from the nursery, so I can report pretty quickly if things are changing with the parents or with CPS. We try, sometimes it just gets crazy busy, but we try just to maintain those lines of communication because we are new and there's nothing really like us out there. It is us trying to find a system that works best, electronic monitoring system, electronic monitoring, EHR, sorry, that works for our babies, but then works also for our parents. And we're not a hospital, we're not a treatment facility for parents. So there's really not a lot that we have to go on. So like Sean said, we are building the plane as we fly it. And, we don't fall into a certain role. We take babies that are going into foster care. We take babies that are going home with their parents. We take babies that we're not sure where they're going or who's involved. We take babies that have been abandoned at the hospital. So every baby's situation is different, and things can change really, really quickly when you're dealing with babies involved in the state's custody and court system. Also, things can take a really long time and just drag out forever. So just trying to communicate with everybody and keep everybody involved is really one thing that we're really working on. And I do think we are doing a lot better coming from where we were to where we are now. But definitely we have some growth, and it's been, one of those challenges because we just don't have the systems and equipment and stuff that may be more helpful to us.
Thank you. All right, just a couple more questions and then we're going to dive into Q&A. So if anybody has questions, I'm only seeing one in the Q&A. If you have them, go there, get in line, get your question in. Jeff, this next question is for you. Can you talk a little bit about what kind of outcomes we're seeing for our infants, whether that be medically, developmentally, severity of withdrawal, length of stay, anything like that?
Yeah, so regarding the severity of withdrawal symptoms when they're admitted to Maddie's place, it really varies depending on their substance exposure. Some of them are quite irritable and fussy, and any little bit of noise or light seems to get them upset, which is kind of reference to Misty was mentioning earlier, just having that recovery nursery very quiet, very dark, and other babies on the flip side are just sleepy. They just are not arousing very well, and so those both have their own areas for different reasons why they won't be, say, gaining weight. And so depending on the severity of when they're admitted, that often we've seen has contributed to their duration of stay with Maddie's place and the extra level of support and therapies that are necessary. Long term, I think we still have a lot of working with WSU, a lot of studies that are necessary to determine what are these outcomes going to look like in the coming years. I can say in the longer term, for some of those infants that have come to see me outside of Maddie's place, once they've left and kind of graduated, it's so positive to see those moms and those dads come in and see me, and I can see their babies just growing, now becoming much bigger and eventually toddlers here. And so that's just a very big positive.
Well, and for those, if anybody's confused by the slides that I had up on the screen, I was just sharing, Jeff, I don't know if you can see those, just some of the results from the WSU study that was done on Maddie's place that wrapped up last summer. We're measuring outcomes for infants, and so the result of that study was showing some statistically significant improvements for those babies that had come to stay with us. Across, we've sort of got 4 domains that we typically take into account. Sean, do you want to talk at all about any of the work that we did with WSU, or would like to continue? Oh, I think you're on mute.
Sorry, this particular tool, this Hopkins tool, has not been formally recognized by our state healthcare authority. And I think probably we even have some questions amongst our clinical staff as to how valuable it is. One of the issues that we have with this is that we don't have a control group to compare this with. And even although so we had an independent study that was done as a part of our pilot project. It was over a 1-year period. It was cut back quite significantly, so it was only a $190,000 study, which isn't very much. So basically, the study focused on 3 things: the prevalence of NAS in Spokane County and in Washington State, and then the outcomes with our infants and outcomes with our moms. Because of the lack of, it was just not a large amount of funding, it wasn't an in-depth study. So NAS, for example, on the prevalence, well, we found that we have a real problem in Washington State. It's about twice the national average, and in Spokane, it's about 3.5 times the national average. What we also found is that we don't have any prevalence data in this state for the last 4 years, and in the United States for the last 5 years. So that was probably the main thing that came out of that, is we don't have a clue what's going on in our country or in our state or in Spokane. So that was number 1. Number 2, WSU did use this Hopkins tool, which was based on this article that came out from Johns Hopkins and Harvard Medical School in September 2021 that used this particular tool. So we did collect the data on that over a period of a year with our first 71 infants. And it did show, based on that criteria and those measurements in the 4 different domains that Katie mentioned, significant improvement between the time of admission, the midpoint of when they were here, and their discharge. Although the report said that there was a statistically significant improvement, the healthcare pointed out that there wasn't a control group. So we don't know how these infants would have done aside from Maddie's place. So I think there's a lot more work that is going to need to be done and research that's going to be done on actually how you measure improvement at a facility like ours. And then on the outcomes for our moms, all they did was sort of a sociological, they did 15 interviews with 15 of our moms who all said that, basically they weren't sure if they'd still be alive if it hadn't been for Maddie's place, or they said they're pretty sure they wouldn't have had their infant if it hadn't been for Maddie's place. But there's actually a lot of research that's been going on. In fact, one of the things I'm super excited about is Ryan Moran, who's our new director of the Healthcare Authority here in Washington State, came from Baltimore, Maryland, and he received his doctoral. He got his doctorate at Johns Hopkins, and his doctoral thesis was on peer recovery and looking scientifically at what is it about recovery that has such a success, such a high, or peer support that has such a high success rate, which is, I think, what we're seeing. What we're seeing is, okay, 73% of the moms that have spent a night or more with their babies here are in recovery. Scientifically, why is that? We know what the components are as far as compassion and dignity and coming alongside and training them how to be parents when they weren't parent. They've never had that to see in their own homes, and that. So we know that we're really onto something. But this is just a ripe field for a lot of research. I will say one last thing on the research part. WSU has filed an application for an emergency request for grants that NIH sent out in April because they're concerned about animal studies that have been done on with fentanyl and neurobehavioral development. And so the idea would be to study 250 babies in Spokane, 125 that had been exposed to fentanyl and 125 that had not, but had the same socioeconomic trauma factors. But just didn't have exposure to fentanyl. So we're hoping to hear whether that grant application is going to be approved or not. It'll be $2.5 million. Maddie's Place would receive $500,000 for that study and would have to hire a couple people to do that. It would be 18 months longitudinal study on 250 infants over a 5-year period. So we're waiting to hear on that. But the bottom line is we have a crisis going on in our country, and we don't have good data as how bad it is, and we don't have longitudinal studies on the impact that it's having. So we're kind of behind the curve. But anyway, again, we're trying to do what we can to get as much data as possible and as much study as possible. I should say one last thing, we're hoping that some legislation that I've been working on for about 4 years now called the Miracle Act is going to be introduced for a second time in Congress later this week. And that would direct Health and Human Services to do a 3-year study of how bad this problem is in the United States, state by state, tribe by tribe, and also specifically look at the outcomes at the 5 NAS clinics in the United States. So once we get some federal money that's devoted to this, I mean, it's going to take forever, but it'll be a start. And so anyway, that's something we'll talk more about on November or December 11th, I think, is our 6th and final webinar, and we'll tell you kind of on the legislative front what's going on, because there's quite a bit there. But we need more studies, we need more information. I don't know that the Hopkins tool is the end all and the be all, but that's what we did with WSU last year.
Thanks, Sean. Okay, last couple of questions here. Kim, I know you sort of talked a little bit about it earlier, but and families' ability to sort of come back to Maddie's Place after they've discharged, but what does follow-up look like once a parent and a baby or a family has discharged from Maddie's Place?
So when a baby discharges from Maddie's, they have to have a pediatrician appointment set up within the next week or so they can get follow-up care by a provider, so we can make sure that they're not declining in their weight or going backwards. And then we do a follow-up visit with them. We are starting our aftercare program, so it's not 100% in place yet, but our goal is to do a home visit with them within 30 days And then that would be between a social worker and a peer support going out, checking in on them. We also have one of our staff that does a call and check in on all the babies. And if the babies are with their parents, then we check in on the parents. That's currently what we're doing. But we really want to build our program to be at least seeing them the first 30 days, 60 days, 90 days, and then at 6 months and at a year. That's our goal. And then just to be able to kind of follow the babies and parents a little bit long term. We have contact with a lot of our families informally, but we would like to offer services up to a year. And then Sean mentioned earlier that we can offer respite. And so we do allow a family to utilize respite. So they could call up and say, hey, I need to go to a funeral for the weekend. Would it be okay if baby comes and stays there over the weekend so I can go to the funeral? Sometimes a parent has to have emergency surgery and we can take baby, but it's a familiar place for baby. And then the parents know who will be caring for baby. So that's always a great way to stay in touch with them. Again, they can come in and see us anytime. And if we have stuff for them, diapers, food, clothes, formula, whatever they need, we're always happy to help with that. But formally, we are building that extended program to support them within the first year. And then we can actually have really good data to know, are they still in recovery? Do they still have their baby? Are they involved with CPS or has their case closed? So we really want to track that more efficiently. We've known that we need to track it and we have been doing the best, but now we're really putting some resources to that so we can follow them for up to a year.
And I think just adding to what Kim is saying, from a financial standpoint, I mean, we've proposed to the state legislature that we get paid for 45 days, both by Medicaid and with our state Department of Children and Youth and Families, kind of a per diem rate. But we're realistically going to need to have other sources of revenue, and these clinics need to have other sources of revenue. And so I think starting to build a case for what happens after the dyad or the infant leaves after 45 days is going to be important, because we know we're providing enormous value, whether it's in clothing or food or just additional resources or the gatherings that we have, the community that we're building. And so, but we need to quantify that. And so we're trying to do that also. But we're trying to set the stage for getting funding for that part of our services too.
And then we do offer a 24-hour hotline to our nurse on duty. So any of our families can call and say, hey, I'm struggling with baby tonight, and get a real live person on the line and somebody that more than likely knows about their baby and has cared for them. And so sometimes it's a lot easier to get through on that line than it would be just to be trying to contact, through their insurance or their provider, or having to go to the ER urgent care. We're always happy to help if we can.
Great. And then we're going to wrap up. Missy and Lindsay, in case there's anything else that we hadn't touched on in this area, what kind of outcomes stand out for parents? And what changes have you guys seen in the nursery in confidence and bonding, stability, recovery?
I think it's, any of us who have been a new parent at any time, it's the little wins. It's, when their baby holds their head up, it's when their baby rolls over. We do therapies here, we do tummy time, we do all of those things. So these parents get excited just like every other parent does for every baby's first, but it's also things that are wins for them, like the baby drank the bottle for me this time, because their ICSs are so specialized at feeding the infants that when the mom is able to get a bottle finished, it's a big win for them. And then there's their own personal wins that make them feel like they're doing better parenting. So when they have a good day at treatment, or when they are able to come down on methadone, because a lot of them come in with the idea that, they're on methadone, it's not good. And they start to come down on their their methadone. When I know there's a question here about breastfeeding, so they are allowed to breastfeed as, depending on their UA. So methadone does not cross. There's a very small percentage that crosses over. So if they're taking methadone, they are able to breastfeed. And then, so when they finally get to that point, because there are a couple other things that we're looking at. So as their levels drop on some of the other pieces, as fentanyl's leaving their system, our parents in visitation may, still be waiting for their UAs to be to a level that they can come in. So when they finally get that okay, that they can breastfeed, that's a big win. And as those little wins come in, those big wins come in, that confidence goes up. And they just are, they're rejoicing. We're rejoicing. I'm getting teary over here. So Lindsay, you can take it.
I think too, the wins can be, like she said, really small. We have a lot of parents that come in and they've been treated really horribly and they've had a horrible home life. And I can think of one mom in particular. She came in and she was real rough to love. Like, she had her guard up. I can do this. I'll do it on my own. Questioned everything we did, didn't trust anyone, but you got to know her, and she came from raising her siblings at the age of 14 because her mom had substance use. And then, she had just sort of really rough, not very nice, loving people to her. And she walked into the nursery one day after weeks of working together, weeks. And she came to me and she said, "Lindsay, help." And she handed me her crying baby. And I was like, that is a win. Like, the fact that she would come and trust us and say, "I need help," and literally did 3 things, handed the baby back and was like, "You got this," and sat with her. But just that openness, I saw a little bit of her soften. And that sometimes is just such a huge win, that she finally, at the age of 20 some, found an adult that she trusts and that she can be soft with. So I think really building that rapport with them, I see moms come back and they're bringing their baby back to visitation to say, "Hey, look at us." And they're coming to us and they're open arms for hugs, and we're oohing and aahing over their babies, and they just are glowing. And those are wins, because sometimes these people have never had a win, right? They've never been looked at as, "You've done something great." And when we look at them and say, "Gosh, you're such a good mom," or "You're such a good parent," and mean it because they are doing it, is huge for them. And I think that has long lasting impacts. It says often we just need one person in our life that's rooting for us. And that's what we need, is one person. And we might be their first person. And I love that about Maddie's Place.
Thank you all so much. I think we've got a handful of questions in our Q&A section, so we're just gonna kind of ping pong around. Jeff and Misty and Lindsay, I think you guys can maybe speak to this one.
Jeff is off. I'm manning his questions.
Oh, great. In the therapeutic handling sort of section of things, can you talk about what head to toe movement refers to?
Where was that at? Pulling up the we might not be able to see the Q&A. Oh, there we go.
I think, I don't know.
Is that talking about the independence? Like,
I think that's maybe what what they're referring to. If not, Sophie, let us know.
I think it's referring to, sorry, this is Carly. I think it's referring to like movements rather than a horizontal, different, like head to toe movements rather than side to side.
Yeah.
That's what my guess is.
Bounce up and down.
Oh, yes.
This one.
Yes. I've seen babies be calmed in a swaddle, and you're holding them like this and you're literally doing this and they calm.
It has to do with the neuroreceptors and how they handle that. So they do better going up and down versus in a side to side movement. So we do a lot of time on a ball. The head to toe. So they bouncing on a yoga ball. Our ICS staff or even our nursing staff will bounce them up and down on a ball, or do exaggerated kind of a drop movement with them. just holding them and kind of just dropping down with them. And it's really kind of a fast movement. But they just do much better than, traditionally where, you're like, oh, shh, quiet, quiet, back and forth, back and forth. They just do much better with this type of movement, an up and down movement. Sorry, that took us a while. Yeah.
Thank you, Carly, for the clarification. I should have been all over that one.
Of course, it also just in our training, it also helps with their vestibular reaction. So it's not adjusting their inner ear changes.
Thank you. On top of it, Carly is also an infant care specialist. All right, Jennifer is asking, how do you facilitate transferring an infant from the hospital to Maddie's place? Does it require a medical transport team or just a car with a car seat? Kim, do you want to take that one?
Yeah, so we transport all our babies, and I know that when I went to visit Bridget's Path in in Ohio, they don't transport their babies at all. They use AMR for that. But we found that we like going to the hospital and meeting the parent there, if the parent is coming, or meeting the nurse caring for the baby and doing a warm handoff just goes a lot better for us. When we're there and we can talk to the parents and, meet them and introduce ourselves, it goes a long way. And then if our staff can get a really good report from the nurses, that's really helpful. So sometimes I think those get a little bit lost if we didn't do that one-on-one. We have used a medical transport once for safety reasons, and we had a volatile father up there, but other than that, we go and transport them ourselves.
Thank you. And then Misty and Lindsay, if an infant has been started on meds in the hospital, maybe morphine or clonidine, how does Maddie's place wean them off of that? And are meds stopped or slowly weaned, or is there some other option?
They're weaned down slowly. They are required to be on cardiac monitors if they are on those medications, the morphine or clonidine. They are monitored closely, and then they're weaned down. I think I have been here 1 year. I have not been here since the beginning, but I do believe we've only had 3 babies, Kim, that have been on morphine. And so it's not something we do regularly, but we are able to do that. We do have the equipment to do that. But again, we do, because of our staffing ratios and our ability to really try all other options first. We have had babies discharged with morphine if needed, but we have used all other things before that. We've not had to use that, but we do have that ability. It is our WAC that, does say, what we have to do in the event that we're using morphine. It does change your nursing ratios as well here. So that is something to think about. If you already have something in place in your state regulations or not, if this is going to be something that the state is going to have to look at writing regulations for, you really do want to think about that, because with having to have cardiac monitors for these babies, you really do want to think about what your nursing ratios would want to be in that event. So just something to think about, but we would wean them off. But a lot of times we just try everything else that, really that consoling, that swaddling, that, deep pressure, all of those things we have been able. There's been a couple babies we've, the nurses that have been here long-term, like say, this is the baby I would have actually done it on. But we have been able to use other therapeutic methods to alleviate their pain without going to morphine.
Thank you. Okay, and I think that Misty and Lindsay, you guys already addressed the question around breastfeeding and how we support parents in doing that. I'm not seeing any other questions. We'll give it one more
other thing with breastfeeding, yeah. Katie, for our moms that are breastfeeding, it can be very difficult for them to successfully breastfeed solely. Just whether they're staying with us or not, to solely breastfeed takes a lot of time and patience. And a lot of times, since they're also recovering, they're sleeping, it's hard for them to get up throughout the night to either pump or breastfeed. So a lot of times it's just not something that they are able to do without some sort of supplementation, and that's okay. So we want to make sure that that becomes very positive for them as well. Like any breast milk's better than no breast milk, if that's the route you want to take. But it's also okay if breastfeeding is not going to work out for them. So really making sure that it's, no matter how they choose to feed their baby, it is positive. Lindsay is an expert at breastfeeding. So if you have anything to add to that.
I just really encourage my moms when they're coming here and they want to provide breast milk or breastfeed, we hook them up with lactation. And then I just really encourage them to look at this as sort of a medicine. It's a like healing for their gut. And so every little bit that they can provide is great. But then also balancing it with what mom needs as well. So it's been a very positive experience for our moms, and it's always an option. So I love it.
It's amazing. Well, is there anything before we sort of wrap up our time together that we didn't cover that you want to share?
I'd like to say something just to end this with. I know we have a small but quality group of attendees, and we do believe that a lot of people are watching these online. We think there are about 240 people around the country that are following these webinars. But of the group that we have, I just wanted to mention Heather Perry and Julie Davis and Kirby Orr are all highly qualified RNs in Oregon and part of our Oregon cohort. And I just want to let you know that we have 3 managers in Portland that have agreed to be the managers. So William Bonheim, who I know has been in contact with you, and then also Marvin Seppala and Ross Yoakum. And so those agreements were signed yesterday. So we're formally ready to get going down in Vancouver. So I'll be getting out an email to you all in that cohort. There's about 12 or 14, I think now, if we add Vancouver folks, Katie. And so we're making moves in Oregon. We're ready to start raising money down in Portland. So I just want to let you know that. And then we also have Lynette Serlo, who is listening in. And Lynette, for all of you, is an amazing woman who's the founder of Generation O, which I think has 7,500 members around the country that have adopted or fostered children. And it's just they have just Google Generation O, and you'll see all sorts of wonderful educational materials and seminars around the country. And Lynette is part of our Florida cohort, and we have a really, really strong cohort there. And I think we'll have in the chat kind of the information on Generation O. I think that's also on our website. But we're looking forward to working with Lynette politically. And so hopefully, Lynette, you can make our December 11th there, because there's lots going on both in DC and locally at the state level. So anyway, it's a small but a very quality audience, and appreciate you all.
Well, thanks for that lead in. So yeah, we just want to thank all of you for being here again today. Thank you especially to my amazing coworkers that lend their expertise and compassion to this work every single day. I think our discussion today really just shows the quality of the care that our babies and families get while they're here. And they definitely feel loved as soon as they walk through the door. So we hope all of you will join us for our next and final webinar in this series on Thursday, December 11th. I know we're headed into the holiday season, but this will be a really important open discussion around some of the moves that we're making. So we're excited to wrap up the series talking about where we're at, where we're going. And Sean spilled the beans a little bit on a couple of pretty big announcements. So you're not going to want to miss that. Please be sure to register. I'll drop that link in the chat here in just a moment. But as always, this webinar is being recorded, and you guys can always reference that back later on our website. And we'll make sure you guys all get a copy, everybody that registered. So Thank you all again for joining us. I just really feel like we're building some momentum for a movement here. I hope you are all having a great week, and we will see you again next time.
And happy Thanksgiving to everybody.
Yeah.
Thank you.
Bye.